Good afternoon. We're going to start cardiovascular system. This is part 3. All right, so I'm going to go ahead and start sharing my, oh no, where's my screen? I'm going to start, no, stop, share. Okay, there we go. Now we should be good to go. All right. So cardiovascular, we're going to be going into and speaking about blood vessels. So, blood vessels, I have a fabulous, of course I do, video that I'm going to put on to Teams with Mr. Hank Green and explaining to you blood vessel and the blood vessel process. Not because he's my nerd crush or anything, just because it's a great video. All right, so first of all, what we understand is arteries. Arteries are any type of muscular wall. They're tubes, and they're basically everywhere throughout our body. Some are a lot bigger than others, some are a lot smaller than others. What is their job? Okay, so arteries have one job, and that is to supply all of our body with oxygenated blood. You need to know that? Yes. All right. They are elastic. That means that they can expand, which is great because that means that they can handle the contractions and the pumping of the heart. And we want them to remain elastic, to keep their elasticity, because when they lose that, that can lead to cardiovascular diseases and other problems we'll talk about later. All right, we're going to go over some of the common arteries. You, as an MA, you need to know this one. This is going to be the artery that you use, I'd say 95% of the time, and that's the radial artery. And we know that the radius, the bone, runs on the side that the thumb runs. So it would only go to figure that the radial artery also runs right along the radius bone, straight up and towards the thumb. So when we go to take a pulse, what are we going to be using? We're going to be using that radial artery. And so the good way to always remember is it's the one here next to the thumb. So make sure you know where that is and be able to identify it. Next, we're going to talk about, you can see my attempts at drawing this in, the brachial. And I wanted you to see how the brachial artery runs all the way up here and down. Now the brachial artery is where we like to take a pulse in children or small kids, because the brachial artery is really easy for us to wrap our hand around the upper part of the child's arm and be able to place our fingers, palpate right here and feel real nicely the brachial artery and get a good pulse. And it's a lot easier than trying to do it at the radial, like we do on an adult. Then the next, we have bilateral. We have both sides, the carotid arteries. Now the carotid arteries are really important. Why? They supply the blood flow to the brain. I think that's an important job. So you want to remember that. You want to remember why they're so important, because they're keeping the brain alive. Without the brain, we're done. Okay? And we don't want any type of blockage like it's showing here, plaques. We don't want any type of narrowing. We want a nice, open, full artery, and that's nice and elastic, so that when that blood pumps and rushes through, that it's able to completely deliver its load to the brain, oxygenate all of the parts that it needs to deliver oxygenated blood to. Here we have the temporal. Now the temporal, we can actually check a pulse here, and you can feel your own. If you're real still, you can actually take and feel your temporal artery, and it runs right along the side, all the way up and through the ear into the forehead, and that's the temporal. And then we have the femoral, and the femoral artery is a very large, gigantic artery, and it's a nightmare. And here's the reason it's a nightmare: because if you ever have a patient with a femoral bleed, you're going to see the, like the pictures of the blood just squirting across the room. This is what you'll have. I had a few 911 calls where I had what they call bilateral femur fractures, and a couple of them where they were open, and so we had femoral bilateral bleeding, and it was a bloody mess. And I can tell you, I'm a big girl, and as much pressure as I was able to put on, it just wasn't still enough. One of the legs I had to place, this one patient in particular, I had to place tourniquet on. And we try to avoid tourniquets at all possible, but I knew there was no way, that the leg was so damaged, so mangled. If I didn't stop the blood flow, I was going to lose the patient. The other one, to stop because what we do to try to stop bleeding is we apply pressure. So what I did was I actually placed my knee. That's how much force it took for me to get the blood under control from that femoral artery. So when I tell you it's a big boy and it's a big pumper, it definitely is. And it supplies all of the lower area. And you can see how it branches off, okay? What you're seeing in this little picture is, we'll talk about in a little bit, but it's an aneurysm, okay? So see how it balloons? All right, so we'll talk about that later. All right, so the back of the knee, we know that we have the popliteal artery. And I like saying popliteal, and it's right in here. We can peek and see it through the muscles here. And you can actually, if you have the patient flex the area lightly, you can place 2 fingers and feel the popliteal artery in most of your patients. And that's letting us know that they have good blood flow to the areas lower than the knee. And then this area here, this is a really important area that we don't think a lot about, okay? But when we think about circulation to the tips of our toes, why is it important that we need to make sure this area is being completely oxygenated and full of the proper nutrients and stuff like that with oxygenation? Because if it's not, that could tell us that there's some type of injury, that there's some type of blockage, or that their patient is having pumping problems, that their heart is not strong enough to make it down. Another time we see a lot of issues with pulses here is diabetic patients. Because remember, I talk about diabetes, and diabetes wrecks the entire body. And one of the things that we know is it affects the vessels. It also affects the nerves. So this patient may be going without proper blood circulation to their toes and not even be able to feel it because the nerves are damaged from the diabetes. So this is why when good tip, whenever you have a diabetic patient, your doctor, if he is an endocrinologist, specializes in diabetes, he should automatically tell you everybody's shoes come off. Everybody's shoes, everybody's socks. If they're not, that's not a really good sign, because a good doctor with a diabetic patient is going to want to see their feet, every single one of them. Not because they got a kinky foot fetish, it's because their feet are one of the first signs that we're really starting to see some complications of diabetes, especially on the bottom, especially with what we're going to talk about is something called capillary refill. That's when Too cute. That's when if I press my thumb and I let go and I count 1, 2, 3, it should be pink. And I hold it, press, hold it, press. That's called capillary refill. And capillary refill lets me know that it's being oxygenated properly. If it's more than 3, 1, 2, 3 seconds, then it could be what we call delayed capillary refill. And that could be an issue for concern. Sometimes it's just because the person's cold, right? Or maybe they been sitting in a bad position or something like that. So changing their position will help. But so capillary refill is another way we can check. And then we always want to check, like I said, with our diabetic patients and stuff, the bottoms of their feet. Make sure there's no sores or wounds or anything like that. And this artery here is called the dorsal, and we can check it by placing 2 fingers on the top of the foot. So right in this area right here, and you can feel a nice steady beating pulse in most patients. And if you can't, that could be a circulation issue. All right, next we're going to talk about the anterior tibia. So we know talking about, once again, a lot of our arteries run with our bones. So we know that we have our tibia up front and the fibia behind, right? So the tibia, the tibial artery is right here behind the tibia bone. And you can see that it's large and that it also runs the length of the lower leg. And then it meets up here and branches with the foot. So this is just another area that we can check. This is a lot harder to be able to, this is not someplace you would go ideally to check for a pulse. It's not going to be, but you just need to know that that's a major artery. Okay, so next we're going to talk about veins. And in the background you see they look like little squiggly noodles, and veins are, their purpose, their job is to carry the deoxygenated blood back to the heart. That's their purpose. So you should know that. That should be something that, you know, if I say veins, you automatically think deoxygenated blood, okay? And they also are elastic, but they're not as thick as arteries, because they don't have that same pressure. When the blood rushes out of the heart, it's going with some force and it's pumping hard. So arteries have to be a little thicker and a little more durable, where the veins, they're not requiring as much force. And because of that, because of their low pressure, this makes them ideal for blood draw. And this is why when we do blood draw or an IV or something, we'll go into a venous, because it's not going to have the same pressure. If you try to go into an artery, you could have a lot of post-bleeding and complications. One of the things that you want to also remember about veins is because they have low pressure. So if we're talking about the veins in our foot, now how are they going to work against gravity if they have low pressure to make it back to our heart? Well, they do that. Oh, don't tell me I don't have a picture. That's very disappointing. They do that because they basically have valves. Let's use this one right here, okay? So let's imagine if we were looking at this vein somewhere, and it's heading all the way, let's say it's going to head back up to our leg. Somewhere in here, there's going to be a little valve like this that opens and closes as blood moves back up towards the heart. These valves open and close. Blood comes in one area, closes off, opens up, goes back to the next, and goes to the higher area. This is how it works. So it's like a little elevator system. Valves are important to remember, especially when we start phlebotomy, because you'll be thinking, Why am I not? And that's why one of the first rules I tell everybody: if you don't automatically, you know you're in that vein, and you don't automatically get blood, pull back just a tiny hair, because you're probably up against a valve. So that's always troubleshooting 101 with veins. All right. So a venipuncture is the process of removing blood from the vein. And we can also supply intravenous, this is an important word to know, medication and fluids to our patient via the veins. Because it's part of the cardiovascular system, it is one of the absolute fastest ways we can get medication into our patient. Okay? And why do we use the veins to draw blood? Because there's less pressure. Next, and I kind of already talked about capillaries because they're kind of cool. I call them the bridges, right? And capillaries are the bridges between our arteries and our veins. Our arteries carry what? Oxygenated blood, and it's taking it throughout all of our body, and eventually it runs its course. Now that deoxygenated cell, right, blood cell, needs to go back up to the heart. And it does that by going through the capillary, the bridge, the little space over, and then making its way to the vein, and then back up deoxygenated, traveling to the heart to go back through into the heart and become oxygenated again in the lungs, and then keep on going and going and going, right? So we know a few things about capillaries: that they're small, that they're thin, and we know that they have a special ability. Because they're like net and almost spiderweb like, we know that things are allowed to flow freely through, all right? And there's actual processes and names. You don't have to worry about that as of right now. If you go into nursing, you're going to have to know all about it. But just know right now that things can move freely back and forth through capillaries, okay? We also know that their capillaries are very, like I said, they're very thin, very wispy, and this is where the exchange of gases and nutrients at the cellular level occurs as well. So, and I'll explain, we have lots of blood in our capillaries, and our capillaries a lot of them are microscopic. If you've ever blushed because somebody said, "Oh, you're really cute," and your cheeks turn red, that's because your capillaries in your cheeks are being rushed with blood. It's an emotional effect, but it's basically just blood rushing to your cheeks. Some people, you've noticed, the blushing or the redness and this and that, certain diseases, or their nose, or the capillaries around their nose are always red. We see that a lot of times with excessive drinking. Capillaries are also ideal because we have that really neutral area, because we have, the deoxygenated, partially oxygenated, right, area where it's mixing and sending it back. So we do a lot of capillary punctures for testing. One of them is glucose. And if you've ever seen a diabetic patient prick their finger, they're pricking the capillary. And so they're able to squeeze the blood out and use that capillary blood to get a glucose level. We do it for numerous other tests as well, especially on newborns and stuff like that. It's just a lot easier, especially we'll talk about when we do phlebotomy, how we do heel punctures with, and it's a capillary thing with babies. All right, so we're going to move on. We're talking about the pulmonary and I can't speak today. Systemic circulation. Aren't you cute?
I love you.
The pulmonary, our lungs and our heart, they're best friends. They work in beautiful harmony together, and we want that. And our cardiovascular system can be divided into the pulmonary circulation, right? And this is the part that we're talking about, the route that takes from the heart to the lungs back to the heart. And then that's process that's all right there up at the heart. And that's what I was telling you. That's the one area where you'll see a artery carrying what? Deoxygenated blood, right? Because the heart itself has its own little systemic type of circulation. It supplies its own blood to itself. It's not combined with the rest of the body. And one of the things that we, as far as the jaw, need to understand is that when we think about the relationship between the pulmonary, the lungs, and the whole systemic circulation, the body, one is not going to function well without the other. One is not, if your lungs and you're having difficulty breathing, you are not going to be passing air, getting the O2 and so forth that you need to supply the systemic circulation with proper nutrients, the O2. So there the body is going to start having difficulties, and over time you're going to start seeing changes, okay, in not only the way the person's heart rate is, their breathing is, the way their skin looks, and then over time it can actually affect organs, and to the point where it can even, eventually, if not treated, lead to death. This video is an amazing video, and I know I say this about a lot of the videos, but y'all don't understand. When I put these PowerPoints together, I searched for ages for the perfect video so that y'all would have something that would allow you to not only see how the words are put into motion and action of what we're talking about, but be able to be kind of part of it. So please make sure you watch this, because I'm going to share this, and it talks about blood pressure, and it talks about the effects on the vessels, and what we were talking about, the arteries, and how the elasticity of them, and that connection between the pulmonary and the circulatory system, okay? So please make sure you watch this. And then, let me check, 25, okay, we're good. So we're going to move on, and we're going to talk about blood pressure. So you're thinking, okay, well, we've already talked about blood pressure. Well, yes. Blood pressure is defined, though, and this is a term you need to know, as the force exerted by the blood against the inner walls of an artery. Okay? And the way that we commonly measure blood pressure is by placing the blood pressure cuff around and occluding the brachial artery, right? And then we listen or auscultate, and we're listening for that sound, because that sound, what did I say the last lecture? That very first sound we hear, right? That's our systolic. That is the heart at work. And that number tells us so much. It tells us, hey, your heart, 120, it's working right where it needs to be. 220, ouch, your heart's working way too hard. And then that second number, our diastolic number, when and I'm gonna show you this. I'll explain it to you with blood when we're taking blood pressure. So our first number is systolic. And then our diastolic, we're gonna come to find out, is the heart at rest. So when we no longer hear the foom, 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 right? So now I'm going to explain all of this. But these two numbers are vital for us to be able to gauge a person's cardiovascular health. Sorry, my cats are having the Catnapolis 500 over there in the background. A person's blood pressure is going to change daily, hourly, depending on what they're doing. If they get hot, their blood pressure can change. If they get cold, it can change. If they get upset emotionally, or if medications, so many things can alter a patient's blood pressure. And it changes, and variations, okay. What we worry is when there is a constant change. It's constantly high, or it's constantly low, or it's constantly fluctuating. Those wouldn't be good, okay? Now, one of the things I want you to write down and know is blood pressure is measured by a sphygmomanometer, and it measures, that's a blood pressure cuff, and it measures in what we call mm, and that stands for millimeters. And then if you remember your periodic table from 7th grade, mercury, the symbol for mercury is H, capital Hg. So millimeters of mercury. So if they ever ask you what is blood pressure measured, it's measured in unit, is millimeters of mercury. Okay? And one more time, systolic is the heart at work, and diastolic is the heart at rest. Okay? The average blood pressure we want to see. Now, this has changed. Back when I was 19 and became a paramedic, the normal was a lot higher. The American Heart Association kind of runs the guidelines and regulates what we want to see with our patients. And it's decreased. This number's dropped. The reason is we know that the lower we can keep a patient's blood pressure, the less cardiovascular problems and diseases that they're going to have later on in life. So we want the average pressure to be the systolic, about 120, that range, right? And the diastolic to be about 80. Now, I need to let you know, everybody has their norm. And when you're like, what do you mean by that? And what I mean by that is that my normal blood pressure is about, hold on to this, about 114/60. And that's technically hypotensive, low blood pressure. But for me, it's my normal. And that's okay because I'm not symptomatic. Now, the opposite might be, you might have somebody who they're in perfect health and their blood pressure is, 130/90. And it's always just been that. Is that idea? No, because we'd always would prefer it a little lower than higher, okay? But we never want, we'll talk about later too, but too low is not good either, okay? Our pulse pressure is the difference between the systolic and the diastolic. And a normal pulse pressure, that means it's 30 to 50 points. And so how can you calculate that and tell is basically there's a, one second. And I've been meaning to put this in my, okay, so if we had our top number, 120/80, so, and what you're going to basically do is you're going to subtract these numbers. So 120/80 would give us a pulse pressure of 40. And let's go back to our lecture. Is that normal? Yes, it falls between the 30 and the 50. And you're like, well, why would that be something we'd want to know? That's more advanced, and with things that they monitor in ICU and cardiac units and stuff like that. But if the doctor ever does ask you what's the pulse pressure, you'll be able to figure that out. You just subtract the systolic and the diastolic and know that we want it somewhere between 30 and 50. All right, I am going to stop at blood because we're not going to go any further. Is there any questions before we move on? I'm going to post these videos. Make sure if you haven't done your SurveyMonkey, please do. And when we hang up, everybody hit the red hang up button, and I'll put this in through YouTube and place it in Teams and WhatsApp. Have a wonderful weekend. Please stay safe, guys. Bye.